Dear Mr. Chairman from Cairo and dear Mr. Chairman from the MENA region, Professor Hazem Abdelrazak from Iraq, Professor Hazem Khamis from Military Academy, Professor Islam Shawqi, President of the Egyptian Heart Association, Professor Sehnaz Karadeniz from Turkey, and Professor Shabin Naz from Pakistan. Thank you very much for attending this important session. And I'm going to talk about challenging Ramadan fasting in diabetics. At the beginning, let me start with appreciation of all efforts done by DAR, Diabetes and Ramadan International Alliance, and it's usually my pleasure to be part of the DAR International Alliance. Let me also appreciate all efforts done to produce ADA and AASD guidelines and consensus for Ramadan fasting for people living with diabetes. But fasting Ramadan in special circumstances and diabetes comorbidities is a major challenge and needs more research. Let me start with some case scenarios. And this is the first case scenario, fasting of the pregnant diabetic lady. And we have two examples. The first example of Mrs. Mona, 28 years old, type 1 diabetic since 4 years. Now she's pregnant in her 3rd month of pregnancy and wish to fast next Ramadan. Another example, Mrs. Noha, 36 years old, discovered to have gestational diabetes during her 5th month of pregnancy, and she wished to fast next Ramadan. Diabetics who are pregnant need optimal glycemic control for pre-existing diabetes or for gestational diabetes, and let me start with the pre-existing diabetes. There is individualized insulin therapy in the form of basal bolus insulin, and to encourage the patient to do SMBG pre and post brandially at least 6 times per day. And this is the target according to the Canadian Diabetes Association. The glucose levels should be tightly controlled, and for fasting plasma glucose, it should be less than 95 milligram per deciliter. This is too tight to be achieved, and for 1 hour postprandial to be less than 140 milligram, and for 2 hours postprandial less than 120 milligram. Then we need a normal glycemic control. Not near normal, it's a normal glycemic control. Too tight to be achieved and too dangerous for the risk of hypoglycemia. Again, these are the targets during pregnancy according to the American Association of Clinical Endocrinology and the American Diabetes Association guidelines. For patients with gestational diabetes, the preprandial glucose should be less than 95. And for the postprandial and post-meal, 1 hour post-meal less than 140, and 2 hours post-meal less than 120. And for patients with pre-existing type 1 or type 2 diabetes, the pre-meal and bedtime blood glucose range from 60 to 99 milligram per deciliter. This is too low to be achieved, but this is the recommendations. And for the peak postprandial blood glucose between 100 and 129 milligram per deciliter, and the hemoglobin A1C should be equal or less than 6%. Again, these figures are very tight and may be accompanied with hypoglycemia and this is the recommendation of all the international entities, that the pregnant ladies with diabetes should be tightly controlled. These are the complications according to different references. Pregnancy itself may be associated with impaired counter-regulatory system and hypoglycemia unawareness. This is the first two important problems in pregnant diabetic ladies. The risk of hypoglycemia in diabetic pregnancy is due to high insulin concentration and failure in the physiological protective mechanism or counter-regulation. Around 45 to 71% of type 2 diabetic females experience severe hypoglycemia during pregnancy. And severe hypoglycemia can occur in pregnancy 3 to 5 times more frequently in the first trimester than in the third trimester. The effect of hypoglycemia on the fetus is controversial. Some data shows that they may cause teratogenicity to the infant. Low level of maternal glucose during pregnancy may cause fetal growth retardation and small for gestational date infant. And in addition, maternal hypoglycemia may also determine impaired fetal beta cell function. All these are complications to the pregnant diabetic ladies, and these are another group of complications in pregnancy: placental insufficiency in the third trimester with hypoglycemia, diabetic ketoacidosis, which may be fatal to the fetus, neonatal hypoglycemia, very high incidence rate of severe hypoglycemia, between 19 to 44% reported during pregnancy. There is a study done in 2008 with type 1 diabetic patients. 45% experienced episodes of hypoglycemia, especially during the first and second trimester. So these are the complications of pregnancy in diabetic ladies. These pregnant diabetic ladies, would you allow them to fast or not? No. The Holy Quran gave a permission to the pregnant non-diabetic lady to be exempt from fasting. So if the lady is diabetic, it's forbidden to be fasting. This is another case scenario 2, diabetes in geriatric times. The risk of hypoglycemia in geriatric population may lead to impaired cognition, and this is increased in the elderly diabetic patients, and older adults may have neuroglycopenic manifestations instead of adrenergic manifestations. So the manifestations in older age of hypoglycemia: dizziness, weakness, delirium, confusion, compared with the adrenergic manifestations of tremors and sweating in younger diabetics. These symptoms may be missed or confused for another neurological deficit like transient ischemic attack, leading to inappropriate management of hypoglycemia. Case scenario 3, a 65 years old female housewife, diabetic type 2 since 7 years, on DPP-4 inhibitor and metformin. And DPP-4 and metformin, they are safe during Ramadan because they do not produce hypoglycemia. But let me complete the case. She's hypertensive on ACE inhibitor plus amlodipine. She is also on clopidogrel aspirin combination, and there is data about the efficacy of clopidogrel during Ramadan, that the effect of clopidogrel is lowered during Ramadan fasting, and we're going to hear this information from Professor Atif Al-Bahari soon. This patient is having recurrent transient ischemic attack. The last one was 9 months ago. This patient is having transient ischemic attack. Would you allow her to fast or not? No. Okay. She has no evidence of other cardiovascular disease. Her hemoglobin A1C is 7.4, and she has advanced retinopathy. The blood pressure is 150/90. Examination unremarkable, apart from mild edema of the lower limb, maybe albuminuria, maybe from amlodipine. She's hypothyroid, and again there is data about hypothyroidism and the increased incidence of hypoglycemia in diabetic hypothyroid patients. And TSH on 100 microgram is 9, and she's on statin. And there is macroalbuminuria, although her GFR is 61, and we're going to hear 2 important lectures about diabetic kidney disease with Ramadan fasting later on today. Can this patient fast or not? No. Okay, thank you. And according to Quran, شهر رمضان الذي أنزل فيه القرآن هدى للناس وبينات من الهدى والفرقان فمن شهد منكم الشهر فليصمه ومن كان منكم مريضا أو على سفر فعدة من أيام أخر يريد الله بكم اليسر ولا يريد بكم العسر. في نفس الآية اللي أمرت in the same surah Quran which ordered fasting, God said that who is ill or يريد الله بكم اليسر ولا يريد بكم العسر، في نفس السورة اللي ادت الأمر بالصيام. Another surah ولا تقتلوا أنفسكم إن الله كان بكم رحيما. Don't kill yourself. This is the Holy Quran, merciful. We did many studies about Ramadan. This is the AASD Fed Fasting and Diabetes Study 2018. And we found that the number of fasting days in Egyptian people was high. Those who fasted more than 20 days in the holy months was 79% of the cases. And according to this study, we had 98% of type 2 diabetic patients, they intend to fast. So fasting Ramadan is very popular for people in Egypt, even if they are diabetic. And according to the DAR survey 2021, and we had 800 patients from Egypt, 92% of the cases had the intent to fast, they intended to fast during Ramadan. This was questioned in the survey, the DAR survey. Did you break your fast because of diabetes related illnesses? And again, 79% of the Egyptian diabetics who fasted did not break the fast due to diabetes complications. Did you have to break your fast during the Ramadan because of hypos? And again, 36% of patients with hypoglycemia did not break the fast. This is very dangerous, actually. And this is another study done by our association, culturally based pre-Ramadan education, increased benefits and reduced hazards of Ramadan fasting for type 2 diabetic patients. It was about pre-Ramadan education and the role of pre-Ramadan education in management of complications during Ramadan and management of hypoglycemia during Ramadan. Another trial was published in the IGF in Busan 3 years ago. And it was also about the role of pre-Ramadan education in Egyptian diabetics. Like we said before, AASD did a consensus in 2021, and we are updating this consensus, but we're going to give you what was done in 2021, and during the coming few weeks, we're going to have an updated consensus, and we need your feedback, please, to help us doing a better consensus. This is the consensus, and it's divided, it was divided, it's 2021, it was divided into very high risk patients who must not fast, high risk patients who should not fast, moderate risk patients, they can fast with help, and low risk patients who can fast safely. And this is the very high risk patients, and I already discussed the pregnant diabetic lady who must not fast, geriatric patient with cognitive disorder and dementia, they should not fast. فرض الصيام أصلاً بيسقط إذا كانت درجة الوعي غير سليمة. يعني الناس اللي عندها dementia, those with dementia are exempt from fasting. Recurrent or unexplained hypoglycemia in the last 3 months, and I'm going to give you a few slides about this topic. And during acute illness like fever and COVID-19 and diarrhea, during the acute event, not after the acute event. These are the high-risk group: old age living alone on insulin or old generation of sulfonylurea, elderly patient with poor health who are unable to fast or having associated comorbid conditions. And today we're going to discuss all these data in details. These are the moderate risk and low risk, and they can fast with some help of their physician. Again, this is the DAR 2020 global survey in older population, and around 54% of cases had hypoglycemia just before iftar. This is the time with the lowest blood glucose, just before iftar. And these are the pathophysiological and cardiovascular consequences of hypoglycemia. Hypoglycemia leads to increased blood coagulation abnormalities, increased inflammation and inflammatory markers, endothelial dysfunction, and sympathoadrenal response in the form of rhythm abnormality and hemodynamic changes. These are the consequences of hypoglycemia on the cardiovascular system, and hypoglycemia can result in ECG abnormalities and blunting of ST segment, R wave amplification, T wave flattening associated with adrenal counter-regulatory response, prolongation of QT interval, and decrease in ST segment. Many abnormalities can happen during ECG examination in hypoglycemic events. Again, this is a link between hypoglycemia and acute cardiovascular events in type 2 diabetes, and this was a retrospective observational study done on more than 800,000 patients. And these patients assessing association between hypoglycemic events and acute cardiovascular event, 3.1% of patients had hypoglycemic event during the evaluation period of 1 year, and patients with hypoglycemic event had 79% higher odds of acute cardiovascular event than patients without hypoglycemic event. This is the fatwa by Dar al-Ifta wa Fadilat al-Mufti especially for the Arabic Association for the Study of Diabetes and Metabolism. احنا طلبنا الفتوى سنة 2012. And this is the fatwa, and let me summarize what was written in the fatwa. فإن غلب على ظن المريض إنه إذا صام حصلت له مشقة أو صام ثم حصلت له المشقة سواء باشتداد وطأة المرض عليه أو احتاج إلى تناول الدواء أو غلبه الجوع أو العطش وهو حال غالب مرضى السكر جاز له أن يفطر بل ويجب عليه أن يفطر إذا خشى على نفسه من الهلاك لقوله الله تعالى ولا تقتلوا أنفسكم إن الله كان بكم رحيما. Then according to the fatwa, diabetic patients, if at hazard, they should not fast. For summary and recommendations, a pre-Ramadan assessment is vital for any patient with diabetes who intend to fast in order to evaluate the risk, to educate the patient to self-manage their condition during Ramadan, to produce a patient-specific treatment plan, and most people with type 2 diabetes can fast safely during Ramadan with the support of their health care professional. A post-Ramadan follow-up consultation is recommended. كل سنة وحضراتكم طيبين. Thank you very much.
Thank you Professor Inass.
الأساتذة من بره موجودين.
كل سنة وحضراتكم طيبين. احنا بنعرف ان رمضان جه لما إيناس تكلمنا تقول لنا على المؤتمر. يعني ما شاء الله هي نشيطة جدا في هذا الأمر وهي بتدينا معلومات بتفيد معظم العيانين وبتفيد كتير من الشباب الأطباء. سؤال طبعا يسعدني جدا ان انا ابقى مع حضراتكم النهارده.